Welcome. I'm James Earl Jones. The quest to combat disease and improve the quality of human life has led to great advances in health care. Many of the most important strides were made in our lifetime. We are a privileged generation. Here's one important breakthrough.
Medical advances and innovations in surgical technology have helped make the post-surgical recovery time for most patients faster than ever before. But for big medical insurers, it's still not fast enough.
There's been a shift with Medicare, Medicaid, and big insurance carriers.
And not surprisingly, there's a large emphasis on cost savings. And this has led to a paradigm shift in the way insurance carriers want surgical patients managed.
What they want to do is try to shorten the length of stay, but still provide as good quality as we were providing before.
Essentially, the ideal situation would be for these patients to go from the emergency room directly to the operating room, to the recovery room, and then be discharged home if that's medically appropriate.
Hospitals are competing to expedite their emergency room process by developing more efficient systems of flow-through for their ER patients.
Flow-through is a concept of a patient presenting to the hospital, their surgical issue being immediately addressed, and then being discharged after their procedure. Ultimately, this shortens their length of stay and saves the hospital and the healthcare system money.
What happens today is that a general surgeon in the community is asked to take ER call at the hospital. And during that day of call, they may or may not have office that's full of patients. And they have elective cases that they've scheduled. And if they're on call, sometimes a patient will come in that needs emergent surgery. Then they have all these patients that have their elective cases scheduled, and it sometimes messes up the elective patients when an emergent patient comes in that needs surgery right away.
Dr. Lawrence Martin is a general vascular surgeon who used to be on call. He knows all too well that some emergencies cannot be put on hold.
If you have a practice and you have an office that has like 11 or 12 patients waiting for you, or 5 or 6 elective operations scheduled, one emergency can wipe out an entire day, which doesn't affect the surgeon that much, but all those patients, we scheduled them for an operation a week or 2 down the road. So now you're looking like a month or so. Then they show up for their operation all excited and ready to go, and I'm stuck doing an emergency that ruins their whole day. And then sometimes they can't be rescheduled again for a week or 2.
To address these challenges, some hospitals are turning to surgicalists, surgeons who specialize in urgent and emergency surgery.
The surgicalist model is very similar to the hospitalist model, where surgicalists are at the hospital 24/7. They're there to service the patients that come to the hospital. The surgicalists don't have any elective practices that they have to worry about and no elective cases that they have to worry about.
The hospital Dr. Martin was on call for embraced the surgicalist model over 2.5 years ago.
If I'm busy doing elective surgery or taking care of outpatients, it's nice that there's a surgeon waiting for somebody that comes in with either perforated diverticulitis or acute appendicitis or a perforated ulcer. That way they're not sitting in the emergency room waiting for several hours for an elective surgery to get finished, or a doctor in his office to get done seeing patients. They just get called and go straight to the operating room.
There's probably a handful of surgeries that surgicalists cover, and they do those over and over again. And as such, they're more adept at doing them. And what results from that is that the patients have a better quality metrics when it comes to that. They have shorter length of stay, their morbidity and mortality data is better, and ultimately the patients are going to have a better outcome for that particular procedure.
I think the surgicalist benefit is threefold. One, it's a cost savings to the hospital because patients leave quicker. 2, you have a surgeon that's developed expertise in this specialty. And 3, the community surgeons can focus on their private practices and don't have to be disrupted by emergent surgical care.
It's sort of that old divide and conquer. Instead of trying to cover all bases and becoming less efficient, everyone's sort of separating their practices and doing what they do well in a higher volume.
We hope this program has served as an inspiration to you. Be sure to join us next time. I'm James Earl Jones.